be transcribing or enabling that or?
We can, yeah, feel free to enable that, make it accessible.
Yeah,
Perfect.
I
Well,
went to the accessibility talk and I'm wondering if this is going to go on YouTube. It should probably have the.
got it.
Yes.
I will go ahead and admit everyone.
All right, welcome, welcome. So good to see you all today. Happy Friday. It's a snowy day here in Maryland. I'm glad that everybody was able to make it in today. We have a really exciting presentation for today's University of Maryland Prevention Research Center Speaker Series, Part 2. Really excited to have Dr. Alcala speaking with us today about understanding policy interventions to address adverse childhood experiences. So I'm just going to do a brief introduction and then we'll pass it over to Dr. Alcala. Can you do the next slide? Great. All right, so Dr. Alcala is currently an assistant professor at University of Maryland School of Public Health in the Department of Behavioral and Community Health. Dr. Alcala's research focuses on two areas. One, understanding health inequities, particularly around race, ethnicity, religion, nativity, and generation. And two, examining the impact of adverse childhood experiences, ACEs, on cancer, cancer screening, and utilization of healthcare. So please join me in welcoming Dr. Alcala.
Okay. Thank you so much for that introduction, and it's an honor to be here with ERC. Let me just get my slides so hopefully everyone can see. I will be occasionally monitoring the chat, so if you have a question, comment, feel free to pop it in. But as was mentioned, today the title of my presentation is Understanding Policy Interventions to Address ACEs. So disclosures, I've got nothing to disclose. On my agenda here, briefly, first we're going to understand what I mean by adverse childhood experiences, go into some depth of the potential ways in which we think ACEs are linked to health, particularly poor health, then discuss recent policy efforts aimed at addressing ACEs, and then discuss a study that examined ACEs screening and healthcare utilization that tries to tie all of this together. So the objectives to this session, as was shown in the intro slide, but just to reiterate, first, to improve understanding of what adverse childhood experiences are and how they are hypothesized to impact health. Then understand what policy changes have been recently enacted to address ACEs in California and examine potential concerns around these policy changes. Lastly, to understand preliminary evidence from rollout of ACEs screening changes in California. So my perspective first in terms of, I guess, disclosures that I do feel I have to make, but aren't necessarily tied into professional ethics. But first, I'm not a practitioner. So my perspective of both the clinical setting and policy changes that impact the clinical setting don't come from the perspective of a clinician. So I lean to anyone who is a clinician or practitioner to tell me what is reasonable, what is acceptable, what the challenges are as they see it, because I don't interact with patients on that level. Although I have worked closely with practitioners on various projects, I still don't take it for granted that I have no idea what I'm talking about when it comes to the patient-client encounter. Next, I have examined the potential impacts of ACEs for over a decade. But alongside that, I'm not a therapist, so I don't understand what that means fully to examine and treat patients who are dealing with ACEs from firsthand experience or knowledge. Next, I have examined the impacts of policy change on access and utilization of healthcare for nearly as long, so nearly a decade at this point. But I'm not trained as a health policy researcher in the traditional sense, meaning that my background is not in health economics, but I do take more of a health equity perspective when trying to examine disparities in access and utilization of healthcare, particularly when examining the impacts of policy changes with that sort of lens in mind. The work here that I'm presenting really tries to combine both of these lines of inquiry. So looking at the health impact of ACEs, along with trying to examine how health policy can impact things. So first, let's start from the top in terms of what we're talking about when we're talking about adverse child experiences. So ACEs, that's what the acronym stands for, encompass really two broad categories. So the first two are abuse and neglect, which get combined into childhood maltreatment. So we're really referring to here collectively experiences happening before age 18. So childhood maltreatment will include abuse, so things we do to children that can harm them, and then neglect, things we fail to do for children that can harm them. So when we're talking about abuse, we're referring to physical abuse, emotional abuse, and sexual abuse. And when we're talking about neglect, typically we're talking about physical neglect and emotional neglect. So in terms of the neglect, which I think people find a little less intuitive to understand, but physical neglect would include things like failing to provide resources for children that they need to survive. So not providing housing, not providing clean clothes, not providing food, etc. And the emotional neglect would be, for example, not acknowledging a child and their need for affection, attention, etc. Household dysfunction is things in the broader environment that a child happens to be situated in that can be stressful or potentially traumatic. So these include things like having a parent or guardian or someone in the broader household who is dealing with mental illness, having a family member who has been incarcerated or is currently incarcerated, having a mother who is treated violently, and we'll talk about here the language in a bit, but this is the original conceptualization, or one of the original conceptualization of ACEs that was really mother focused in terms of the target of domestic violence. Then we have substance abuse among someone in the household, and then parental separation or divorce. So if we look at that list, we've actually expanded, or people have advocated for expanding this list a little bit further, and also changing what some of these mean. So you see the conventional ACEs, which are basically identical to the list I just presented, but now we've moved away from this language of violence towards a mother and more towards language that encompasses domestic violence, more broadly acknowledging that people are not in always cis-normative settings, and that men can be the targets of domestic violence as well. A more expanded version of ACEs has been advocated for that includes things that happen outside of the household, and also potentially inside of the household. But typically we think of these things as happening in the broader neighborhood or social environment. So things like experiencing discrimination. This can be across many different dimensions. So whether it be race, ethnicity, sexual orientation, etc., witnessing violence. And this can include, depending on the setting, witnessing violence in your neighborhood. Or if you're thinking about domestic versus international, if we're thinking about an international setting that is currently undergoing conflict or war, then we might think about collective violence that's punishing groups for existing as they do, or experiencing war and its consequences. Being unsafe in your neighborhood, experiencing racism, experiencing poverty, and many more. So these were advocated for inclusion here in this article in 2015. So what are the origins of the ACEs scale, or really the tool we use to measure ACEs with? It was developed by Felitti and colleagues in the mid-90s. And one of the reasons why I want to emphasize that I'm not a clinician is that the people who developed the original scale were in fact clinicians. So this is baked into our understanding of ACEs, really a clinical perspective. So the items took from existing measures of trauma and modified them or added questions. So the questionnaire design here of it all really wanted to focus on something that could be administered quickly and effectively in a clinical populations, because the clinical population here at hand was going to be Kaiser Permanente. So for those of you who have access to healthcare through Kaiser, you understand what that means. But to those that don't, it's really a one-stop shop for health services, meaning that you can get preventative primary care and your secondary or specialty care all within one campus that really reduces the need to travel large distances and really facilitates the transfer or the handoff from one type of service to the next. So the consequential thing from my perspective from this sort of nexus of the ACEs scale is that the population was relatively advantaged. So I want you to think back to the 1990s. So we're thinking about a time that existed before the Affordable Care Act was enacted, meaning that at that point in time, fewer people had health insurance coverage. And if you did have health insurance coverage, your protections that coverage were more limited. So, for example, if you had a pre-existing condition and you needed to sign up for new coverage, they could decline you coverage based on that pre-existing conditions. So all of this means is that people who did have health insurance were going to be a little bit more advantaged in terms economic status, but also in terms of their health profile than the standard population of the area. And here, the area in question would be Southern California, specifically San Diego. So the original ACEs study was developed in that context. And when you look at the demographic characteristics of the underlying population, they're also not really representative of the surrounding area. So that you had a population that was more white than average and also more educated than average and older than average. So it looks a little bit differently. So if you think about scale development and what that might mean, we're not really encapsulating everyone's lived experience in the same way from this scale. So what does this translate to in terms of scales that we use in research? So this is the ACEs scale that we use in large population studies administered to adults. So typically we ask adults to think back at what happened to them prior to age 18. So these are taken from the Behavioral Risk Factor Surveillance System. I'm just going to run through some of the items that get asked here. First, that measure child abuse, and then the ones that measure household dysfunction. So on this first slide here, we have the 5 items that try to capture child abuse. So at the top, how often did a parent or adult in your home ever hit, beat, kick, or physically hurt you in any way? Do not include spanking. And then this gets coded into ever or never happening. The next 3 questions in the middle have to do with childhood sexual abuse, and they capture certain aspects. So one captures sexual touching, the other one also sexual touching, but being forced to sexually touch someone, and then forced sex on the last one. You'll notice that they all have this 5-year or older age requirement. One of my qualms with the scale here is that I'm not really sure why we want to limit it to only people who are 5 years older than the potential victim here. And then lastly, we have how often did a parent or adult in your home ever swear at you, insult you, or put you down? This can be sort of labeled verbal abuse or emotional abuse, depending on how we look at it. The next items here captured household dysfunction. So here we're looking at the first item capturing living with someone who is mentally ill. Then we have living with someone who was experiencing alcohol abuse disorder potentially. Then we have of street drugs or prescription drugs among someone in the household, living with someone who was jailed or incarcerated, having parents who were separated or divorced, and the last is experiencing domestic violence in the household, so witnessing domestic violence happening in the household. So what does this mean in terms of turning this into a data value? Typically, coding at ACEs scales, as you just saw, what was presented was an ACEs scale. So researchers and now clinicians will assign points for each ACE that is experienced. So either was it ever experienced or was it experienced concretely, et cetera, in the case of divorce and separation. The results are then transformed into a count variable that typically ranges from 0 to 9 or 10, depending on the ACE scale in question. However, we typically don't stop here, or at least a lot of researchers don't stop here. And they then proceed to recoding this measure further. So you get then a categorical or binary measure that is, for example, 4 or more ACEs versus 3 or less, or something like 1 ACE, 2 ACE, and then 3 or more ACEs. But you end up with a transformation that looks very different from the original scale that was used. So thinking about this, perspective. So, what might be some challenges with recoding ACEs like this, if we're thinking about measuring the impacts of ACEs on health and related outcomes? And that is my first question to you. If you have any thoughts or ideas, feel free to raise your hand or jump into the chat and leave a comment. Any thoughts among the audience?
Dr. Aparicio is raising her hand.
Sure. Yes.
So this is, yeah, really interesting. I mean, just having worked clinically with with children and also adult survivors, and also in research. Um, yeah, this seems like sort of, I'm not sure why, I'm curious if there was like a number that they really, like a reason why they picked this number. Um, and I know that there's like this, of course, this cumulative effect. And then also there are some of these that are, it kind of depends on people's whether they've received treatment or not and how they're doing with it and like how bothered they are by it, how much of an impact it's had on them. So anyway, I have a lot of thoughts, but about it generally, but yeah, I'm curious why they recoded that way, like why it's often recoded that way, 3 or less or 4 or more, unless there's some sort of measurement reason.
Got it. And we'll talk about that in a sec. Any other thoughts or perspectives on why we might see challenges from recoding ACEs like this?
I'll jump in. I'd say it doesn't provide any sort of insight. It just sort of reduces the scenario to a number. And I think there's a lot that could possibly be missed when we reduce this idea of like it's severity by number of experiences or doesn't give any insight into type or really intensity. So that's one area of concern that I have.
Great. Yeah, so to combine what we're saying here, you're both right in terms of some of the issues here. So we're treating all of these ACEs as interchangeable experiences. And if you think about what they are, you might question in terms of the normativity of some of these experiences. So now, at the current point in time, in the mid 2020s, we exist where divorce is fairly common. And yes, divorce can be very challenging, particularly for children, but it is still something that is more easily spoken about publicly. That isn't the same for other things, like, for example, experiencing sexual abuse as a child. That is still extremely stigmatized, and children are actively discouraged from family members and society writ large from broader conversations about it. We can also think about the potential ways in which ACEs cause negative health impacts. They might depend on the ACE we're talking about. So something like physical abuse can directly result in you, for example, breaking a bone, whereas something like verbal abuse won't result in that same thing, at least in as direct of a way. So I would argue that we're obfuscating some of the unique mechanisms we might care about, which, if we're thinking about solutions for ACEs, we're then also really limiting our ability to identify appropriate solutions if we're only looking at broad numbers and categories here. So there are other ongoing developments when it comes to the ACEs scale. People have continued to advocate for the inclusion of additional ACEs. So I mentioned a few of them, but the list is expanding basically every day. The rationale for doing this is that the original scale was developed for a relatively advantaged clinical population that might not actually capture the day-to-day of different populations in the US or even globally. Another challenge here is that the ways that we ask these ACEs questions are very dated, and sometimes in ways that are harmful for trying to answer whether or not ACEs impact health. So if you think about that limitation for sexual abuse questions that limits it to only people who are 5 years older than the victim, or older, this is going to exclude, for example, dating violence by similar age peers, which still happens and still can have very severe and lasting consequences they've experienced in childhood. Some topics are not included in scales in a systematic way, so things like experiencing homelessness. Discrimination has been included, but it's still not across many dimensions. So things like religion, weight status is not typically assessed in these discrimination measures. Other things that get excluded, for example, living with a sick parent or living with a sick household member in a way that extends beyond just looking at mental illness and substance abuse. So why does this matter? Our understandings of addressing ACEs will be contingent on how we define them. So if we're thinking of them more beyond the household, then our solutions are going to target places that extend beyond the household. So this brings to the operationalization or definition of ACEs that I propose. ACEs are potentially stressful or traumatic experiences that impact children prior to adulthood. This can occur inside or outside of the home, and it can involve family or non-family. So really taking a really broad approach to what ACEs are, and not here, at least in my definition, not giving a specific example of what we might mean, as I think the list of what ACEs are is continuously evolving. So now let's understand or try to understand a little bit about how pervasive ACEs are. So a recent meta-analysis of 206 studies around the world found that most adults, about 60%, report at least one ACE. So if we're thinking about the number of people who are exposed, most people are. Certain groups, however, are disproportionately impacted. So people with mental health conditions are more likely to report ACEs. People with substance use disorder are also more likely to report, and people with lower socioeconomic status. Among specific studies conducted within the United States, we see that certain demographic groups, racial ethnic minorities, are also more likely to report. LGBTQ folks also more likely to report, et cetera. Generally, more marginalized groups are more likely to report ACEs. So now let's look at ACEs in or trends in ACEs in the United States specifically. So this is data that track the prevalence of ACEs specifically in the BRFIS. So the Behavioral Risk Factor Surveillance System, or BRFIS, lets states include questions about ACEs, the ACEs module that I showed you earlier. The one challenge, though, there is that not every state elects to include these questions. So this is taken from the sample of states at any given year that have chosen to include those questions. Generally, what we see is that the reports of ACEs are on the rise. And here we're looking at data from 2009 to 2022. So the number of people reporting at least one ACE has been increasing steadily during this time period. And on the potentially more alarming end for people who are going to be flagged, and we'll see how that is defined later, but flagged for being at higher risk for health conditions, the people who experience 4 or more ACEs are also on the increase across the same time period. So thinking about this, what might be happening here? So why might we see an increase in the reports of ACEs from 2009 to 2022? Any ideas from our audience today? Again, feel free to comment or raise your hand if you'd like to answer. Okay, so from Jamie, are more people seeking therapy or behavioral health services? So more screening is being done. That might be the case, but I'm not sure that that would capture. It might be the case that more people are seeking therapy and behavioral services to deal with the impacts of ACEs, but because this data is being collected from general population surveys, i.e. not from clinical samples, that wouldn't necessarily capture it here. Comment from Swati, questions related to previous discussions about including ACEs. Curious if something more subtle like emotional manipulation by a parent or close family member is included on the scale. That isn't explicitly included. We see something more akin to that in actually our measures of elder abuse, like financial manipulation and more extended measures like that try to capture those things. Abigail or Abby, maybe greater awareness about what ACEs are and or comfort talking about ACEs. So that might be at play in terms of people just being more comfortable with having conversations about this. But the way the questions are, they aren't specifically told this is an adverse childhood experience. So they're really asked the specific questions rather than being told we're gauging the number of adverse childhood experiences experienced, at least in the stem of each of the questions. So it's a little bit harder for them to know that that's what is fully happening. But basically, I'm not really sure what is happening, which is why I pose the question, because we don't know fully what is happening here. We've had happened during this time period that people have hypothesized might be related to ACEs is we had the pandemic. So there's been a lot of discussions about what it meant for people to be stuck at home in homes that were potentially abusive. So if we're thinking about that, this 2020 to 2022 time period where we do see an increase, that might be some of what's happening here. But we don't have really great data that tested that in really any meaningful way. So what are the health impacts of ACEs? So ACEs have been associated with a variety of risky or negative health behaviors, including sedentary behaviors, increased use of tobacco products, including combustible cigarettes, e-cigarettes, chewing tobacco, etc., increased use and abuse of alcohol, increased use and abuse of drugs, missed days of work. In terms of conditions, there are various mental and physical health conditions that ACEs are associated with, including increased risk of obesity, diabetes, depression, increased suicide attempts, STIs, heart disease, cancer, stroke, COPD, and broken bones. When it comes to the strength of these associations, the mental health outcomes are typically more strongly associated with ACEs, and of those, it's suicide attempts that have the highest and strongest association with ACEs, with over 10 times the odds among people who have a high burden of ACEs. So, a really big impact. And if we look at zooming out what the impact of ACEs are on life expectancy, if we're looking at people who've experienced the high number of ACEs, here in this figure and analysis, this is based on people who have 6 or more ACEs, so a fairly high burden versus those who experience no ACEs. We expect to see a 20-year difference in life expectancy in these two scenarios. So what are the health impacts of ACEs when we look at the economic impacts and also the impacts for any given condition? So this is an analysis done a few years ago from published in the Lancet Public Health, but they looked at estimating the cost of ACEs, and they estimate that an annual cost of 73 billion was stem from ACEs. And then they analyze each or several health conditions and health behaviors to estimate what percentage of them were actually due to ACEs. So we see the biggest contribution being among illicit drug use. So that ACEs accounting for 41% of that. And in terms of health conditions, we have the biggest contribution to depression. But even among the weaker contributions here, in terms of what I study specifically, 10% of the variation in cancer is associated with ACEs. So overall, ACEs are very prevalent and also are associated with a myriad of health outcomes and have a big financial burden on our society. That brings us to our first question here that I want you all to think about, at least for a bit. So what might be some of the potential ways that ACEs can impact health? So anyone can unmute or just type out something in the chat in terms of how you think ACEs might impact health. So greater burden of chronic conditions, yes. I guess specifically here, so what might be the mechanisms that lead to that? So Dr. King Marshall, yes.
Okay, sorry, it took me a while to find the hand. I would say, for example, behaviors like perhaps we might see a difference in health behaviors if they aren't necessarily seeing or given the opportunity to walk outside and eat healthy fruits and vegetables. Then I think that might be one of the mechanisms that's impacting cancer, diabetes, obesity differences. And then I would also say just chronic stressors like the wearing down of the body. I think there's been some research as it relates to chronic stress and the biological impact, physiological impact it can have on the human body.
Great. So two mechanisms here potentially highlighted, one being what we might call risky health behaviors being adopted, and the other peer being chronic stress exposure. So we have from Jamie, increased stress, which can create inflammation and higher levels of cortisol that can create higher risk for autoimmune disorders or other chronic conditions. So yes, to hear this stress pathway being mentioned. Swati, indirectly, it could cause relational conflicts that again cause mental health impacts. So yeah, here are some indirect way in which maybe the way you interface with people when you have a history of ACEs can make you more likely to have conflict with others, creating a negative feedback loop here. Emotional insecurity, yes. We have a lot of research on attachment styles coming from their association with adverse childhood experiences, and there are associations with insecure attachment style, for example, and experiences of ACEs.
Dr.
Any of, yes,
is raising her hand.
yes.
So some of these were on the slide earlier, but alcohol use and like heavy alcohol use over the lifetime, and also the way that alcohol use creates risk for other experiences, such as perpetrating or experiencing directly as a victim sexual assaults implicated in 50 to 75% of assaults. Comes to mind. Also, risky sexual behavior. We had that on there too, just like promiscuous behavior, whatever, like um, using substances while engaging in sexual activity. So it's just a lot of other potential exposure to STIs and unintended pregnancy, depending on the type of sexual activity.
Got it. Yeah, so a lot of risky health behaviors, or what we might call risky health behaviors. Okay. Seeing another comment, increased use of tobacco. So yes, we saw earlier that I mentioned that it is associated with increased use of tobacco products. And from my own research, it's not just cigarettes. So we know it's e-cigarettes, it's chewing tobacco, and really tobacco products across the board. Okay, so now let's think broadly in terms of how ACEs might impact health, and then we'll talk more specifically about some mechanisms. So if you've heard of the life course perspective, that is roughly what we think is happening, or roughly a good frame for what we think is happening when it comes to ACEs. So ACEs are something that's happening early in life, so after birth, and then that leads to a cascade of events that feed into each other, that produce the risk of disease and death, or early death specifically. And we'll talk about what these mechanisms actually look like. And this comes from a theoretical framework that I published over a decade ago. So here, a few pathways: biological dysregulation, and I'll talk about these each in a little bit, viral exposures, deficits in emotional processes, social and cognitive deficits. So to Dr. Jackson's point in the chat, brain development, adoption of quote, risky health behaviors, and lower socioeconomic status in adulthood. So let's talk about each of these briefly. So we're talking about biological dysregulation. ACEs are associated with higher allostatic load, or biological wear and tear in midlife. Basically, they're making your body age faster, and we have various different measures of that. So the higher your burden of ACEs is, the more rapidly you are aging. We've seen this with some markers of these, for example, telomere lengths. So telomeres will shorten as you age. They shorten faster if you've experienced ACEs. We also have other processes biologically at play, so increased inflammatory response, which is associated with many different chronic conditions, stress hormones being over or underactive as a response to this chronic activation. We also can exhibit epigenetic changes, and this is coming more from animal studies and what they experience in response to chronic stress exposures. Here we're talking about methyl groups being added to DNA or on top of DNA, and this effect is positively correlated with stress and trauma. So this methylation is increasing with increased exposure to stress and trauma. Methylation is important because it can alter how genes are expressed. So this might increase expression of, quote, bad genes and suppress expression of good genes, depending on how the methylation manifests itself. Next, and this is a contribution of mine to trying to understand this, because I really hadn't heard of this being discussed, but it seemed theoretically feasible in terms of how ACEs might impact health. So some ACEs may directly lead to the transmission of viruses that are known to cause cancer or other diseases. Here, the ACE of interest is going to be primarily sexual abuse, since it can lead to the transmission of blood or bodily fluids, although physical abuse can also allow for this in some cases. Relevant viruses to consider here: HIV, Hep C, HPV, which is going to be linked to a variety of different cancers, genital warts, etc. And it is going to really be the perfect environment for the diseases to develop and go untreated, because if we think about the people experiencing the abuse and potential viral exposure, they will not be the typical targets of screening efforts. So we aren't screening children, for example, for cervical cancer. We aren't screening them typically for Hep C, etc. And they're also then at the mercy of their household environment in terms of whether or not they get the appropriate care in response to potential viral exposures, which might be compromised if we're thinking about an environment that is abusive or neglectful. Next, we can think about emotional and cognitive deficits that can result in response to living in an environment with ACEs. So ACEs impact how people learn. People can become less sensitive to rewards, so they counterintuitively seek rewards more often or in larger amounts. So this is a rewiring of the brain that really changes how people are seeking anything that can be rewarding. So this can include things from addictive substances to attention from others, etc. People are changing how they respond to rewards. They're also potentially less sensitive to the consequences of their future actions, or what is called temporal discounting. So they prioritize a reward now over future benefits. So here, oftentimes when we're thinking about what we ask people to do in public health, we're asking to consider rewards in the distant future in exchange for them doing something now. So if you start exercising now, you're going to experience better health when you're in retirement. Or if you start engaging in healthier dietary patterns, your risk of diabetes will decrease 20 years from now. That's typically the proposition that we sell to people. However, in the context of ACEs, in which this temporal discounting might be occurring, individuals might favor the immediate rewards, which might be things like the risky health behaviors, which we'll talk about in a second. So they might favor the stress relief that can come from smoking a cigarette, or the social acceptance that might come from engaging in a variety of risky health behaviors over the potential to avert some chronic health condition later in the future. So this is all going to be accompanied by rewiring in the brain. ACEs also impact how people react to stress. So not only are they stressors, but they will impact how people are reacting to stress. So is some of the work you are discussing how early in childhood or later in childhood, or this measures along adults? So a lot of this is coming from more adult studies. We don't really have good data in terms of what this is doing to children at this point yet, but that is a good question. It's more hypothesizing what is happening to children specifically. ACEs are also potentially impacting how people react to stress. So emotional reactions to stress may be heightened among those who experience ACEs. And this can also be accompanied by a compromised ability to control reactions to stress. So you stay elevated in your stress response, meaning that that stressor will have an emotional response that is longer lasting. Thus, a person is less able to deal with stress, placing them at a higher risk to self-medicate to deal with stress. Next, we have social deficits. So individuals who experience ACEs may learn that those around them cannot be trusted. In the context where the ACEs are happening, this might be adaptive. So it might make sense not to trust people in an environment where they're being abusive, neglectful, etc. But it might be maladaptive in the long term. In particular, children may not trust others to help them with the situations in which ACEs are occurring. So if you think about people who are in professions, whether they be teachers, clinicians, etc., they may not turn to them for help with their environment. Also, a child may not feel that they have access to social support and may then rely on self-medication. So that they're learning that they can't turn to others around them in their environment and must instead deal with their stressors some other way. We do have some data and evidence in terms of what this means in the specific context of trust in the medical system. So ACEs are associated with eroded trust in the healthcare system. Young adults with a history of ACEs are less likely to trust medical professionals. They're also less likely to trust advice received from doctors, nurses, and pharmacists. So basically, those who can help mitigate the health impacts of ACEs are more distrusted among those with a history of ACEs. So a negative scenario there in multiple contexts. Next, risky health behaviors. So why are survivors of ACEs more likely to engage in risky health behaviors and less likely to engage in protective health behaviors? There's a few potential explanations here. The biggest is this idea of self-medication. So the stress and trauma resulting from ACEs may be temporarily alleviated by drugs, alcohol, eating, and sexual activity. Felitti noted in his interviews with some of his patients, again, reminding you that he was a doctor, so he was originally interested in studying ACEs because he was trying to figure out why his patients were exhibiting chronic conditions, and his line of questioning with his patients led him to make some observations, one of which he reported was that some of his patients described deliberately trying to gain weight to become unattractive to potential abusers, so that the negative health behavior becomes a protective mechanism to avoid re-victimization. Another thing that might be happening here is learning from parents or guardians or others really in the household environment as part of a larger neglecting or abusive environment. Positive health behaviors may not be modeled for children. So we also have to think about how learning is occurring in a household environment where your positive health behaviors, like going to the doctor regularly, brushing your teeth, etc., modeled to be picked up by a child if they're not being modeled in other contexts specifically as well. I argue that we can extend this logic also to the context of healthcare utilization. So healthcare utilization is another health behavior, and individuals can avoid this behavior when it comes to ACEs, specifically preventative healthcare utilization. So we have some evidence to suggest that individuals with a history of ACEs are less likely to engage in certain kinds of health services. On the flip side, they're more likely to use the ER and more likely to use behavioral health services. Next, we have educational success. So the impacts of ACEs is seen early in terms of SES or predictors of SES. Children who experience 3 or more ACEs are more likely to fail a grade, be unable to perform at grade level, and be labeled as special education. This is going to set them up to be less likely to graduate, more likely to drop out, and thus have limited socioeconomic status as adults. So if you think about what's happening here in terms of educational research, we know that it's very important or consequential where your child gets tracked in terms of their educational opportunities. So if they're labeled as special education and given that track in terms of educational services, that might limit their opportunity to get into things like honors classes, AP classes, as they get more advanced in their education trajectory. A big issue here is also going to be the cycle of poverty. So ACEs are more common among children in low SES families, which makes low SES in adulthood also more likely. So this cycle of poverty and cycle of abuse and violence are really moving together in tandem. Recent work by Moore and Stoddard suggests that the association between ACEs and dropping out of high school is mediated by worse mental health, meaning that individuals experience ACEs, their mental health worsens as a result, and then that leads them to drop out of high school. So what can we do to address ACEs? And there's really a few broad targets here if you want to think about them in the crudest of terms, but we might think of ways in which we can prevent ACEs or trying to lessen the impact of ACEs if they've already occurred. So upstream targets can include things like investing in society to make ACEs less likely to occur by tackling issues like poverty, racism, sexism, homelessness, etc., so that we remove these broader societal stressors that will trickle their way into the household. On the downstream, we can try to identify people who are exposed to ACEs and give them social and economic resources to prevent the negative impacts of ACEs. So we might, for example, here invest in high quality healthcare, educational opportunities, trauma informed services, which could include both trauma informed education and trauma informed healthcare. But any other ideas of how we might try to address ACEs? Anyone in the chat or can raise their hand or unmute themselves and share. Yes, Dr. King Marshall.
I would say parenting education, like just having conversations with parents and guardians about these areas of concern and the long-term implications as it relates to prevention. Just really having a conversation so that they are aware what that looks like and what it might have looked like for them in the past. Because I think some of these things might be normalized if it's been experienced by generations, and then opportunities to prevent it, happens through communication and advocacy.
Great. Other thoughts or ideas? As a follow-up here, I think I would ask, what do you think is the more predominant paradigm in terms of how we address ACEs as a society in the United States? So my perspective is that we generally look at this from a criminal justice perspective, or by criminalizing the behaviors and trying to punish people from doing them. And if you think about what ACEs are, this is also, again, creating potentially a feedback loop. So if we punish people for being neglectful, and that leads to parental separation or family being separated from each other, that solves quote unquote one ACE by creating another ACE. But I would argue that as a society, we've often taken this criminal approach to dealing with ACEs. So this brings us to the question of what is being done to address ACEs and looking at a specific example. In California, ACEs were a key issue raised by the state's first Surgeon General, Dr. Nadine Burke Harris. So if you haven't listened to her TED Talk, I highly recommend it. She does a really good job of succinctly explaining ACEs and why she thinks they're important. But California was the first state in the nation to have a state surgeon general. So this was not a thing that existed before the recent past, and it's still, I believe, the only state to have a state surgeon general. She argued that ACEs are proxies for toxic stress exposure. So this is interesting because she is not really interested in understanding the specific mechanisms per se of a particular ACE, but rather saying that ACEs are stressful and measures of toxic stress exposure. So it seems like we have a lingering idea for how we can address ACEs to teaching life skills early, like emotional regulation and stress management. Yes, so we can teach people how to manage their stress or reaction to stressful events. And maybe that happens outside of a therapeutic context, so it's more widely dispersed given how often ACEs are occurring, but it can also include or happen in the clinical context. So what Dr. Burke Harris argued was for the screening of individuals in the clinical context specifically for ACEs. So this then resulted in a few changes in California. So thanks to her advocacy, the California Department of Health Services began paying Medi-Cal. So this is the state's version of Medicaid. They began paying providers $29 to screen children and adults for ACEs starting in 2020. This was accompanied by a 2-hour provider training program called Becoming ACE Aware that covered topics around ACEs and ACEs screening. Providers then had to self-attest that they completed the training in order to receive money for the screening. Interesting from a policymaking perspective, the funds for screening originally came from Prop 56, which increased tax on tobacco products, but this expired in July 1st, 2022. Since then, the funds for the screening program have to come from the general budget in California. This policy change also set forth billing codes that reflected the results of screening. So they reflected broad categories that are noted in the billing process. So after a screening tool, and a screening tool is administered to a patient, the results then correspond with one of the following classifications. So scores of 3 or less were coded as low risk, and scores of 4 or higher were considered positive and include or recommend some kind of provider recommendations to the patient when they receive a score of 4 or more. So the objectives or the learning objectives of the ACE Aware training are presented here. So first, they wanted individuals to be able to define adverse childhood experiences, their prevalence, and health disparities in the prevalence data, understand toxic stress physiology and related impacts on health, including underlying biological mechanisms. So effectively, some of what we've already done here. Identify how to introduce and integrate ACEs and toxic stress screening into clinical care, aligning with trauma-informed principles. Applying the ACE and toxic stress risk assessment algorithm for assessing risk for toxic stress, which includes a combination of screening for ACEs, identifying the presence and extent of ACE-associated health conditions, and identifying protective factors in determining an appropriately tailored treatment and follow-up plan, including referrals if indicated. And then lastly, identify the Medi-Cal payment requirements for administering ACE screening as part of assessing the risk for toxic stress. So I do believe we take a break in the middle. Am I correct in that?
Yes, you're welcome to give us a little break before we come back.
Okay, so let's take a 5-minute break here, come back at 2 after the hour. Okay, let's reconvene. So, on top of the Medicaid reimbursement or paying providers to screen for ACEs, California followed that up with another change. So, in October 2021, California extended payments for ACEs screening to include commercial health insurance in the state, meaning private health insurance. So this could be private health insurance that you buy yourself independently, that you buy through the ACA marketplace exchanges, or that you get from your employer. So any of those private insurance coverage options would be covered here. For working age adults, most of them are covered by private health insurance. So this meant that collectively so children and working age adults would be covered by some type of health insurance, whether it be private health insurance or Medicaid, that would pay their providers to do some kind of screening. So the logic here, or the idea, at least the best I gather here, is that these two policies would combine to try to do the following. So they would train providers to screen for ACEs and incentivize them to screen by paying them to do so. So the incentive to screen monetarily, at least in the monetary sense, didn't exist prior to these policy changes. So provider could screen if they wanted to, but there was no reimbursement mechanism. Screen patients and then provide them additional care or advice to those with a high level of ACEs, and then screen patients make some kind of change to their healthcare utilization, health behaviors, et cetera, and their health improves as a result. So that's, I think, what the policy change is trying to accomplish. So now let's look at the evidence thus far we have in terms of what has happened since these policies have been enacted. So from January 2022 to September 2024, and this is the most recent data that's available, the reports here for progress aren't released on a regular basis or in a timely manner, I guess. But here we have data that shows that Medi-Cal clinicians have conducted over 4.5 million ACEs screening, representing over 2.5 million patients. So the discrepancy here is that some people are getting screened more than once. And you might question whether that is the best thing to be doing, since in theory, those numbers shouldn't be changing, at least for adults. And then we have, in terms of the number of people who've been trained to do this screening, vis-a-vis the ACE-aware training, we have over 49,000 individuals have completed the ACE-aware training. And what you can see here is data from the state that shows where those high levels of ACEs are being reported among Medi-Cal patients here, ages 0 to 20. So we have here in the northern part of the state, which is the more rural part of California, that you have those rates of 4 or more ACEs being highest relative to other parts of the state. So the burden of ACEs, at least as captured in the clinical population, is not geographically distributed in an equal manner or an equitable manner. So progress thus far. We've also conducted some studies to try to assess the impact of this policy change. So in a study that we published last year, we found several disparities and inequities in this screening itself. So basically examining who is getting screened, what their attitudes around screening are, etc. So people with a high burden of ACEs were more likely to be screened. And I think that this overall is a positive thing, or at least identifying the correct people we should be screening if they're the people who are also more likely to report ACEs anyway. Latinx individuals, older adults, those were employer-sponsored coverage, and then the uninsured were less likely to be screened. So some demographic groups and people with certain kinds of health insurance are less likely to be screened, unsurprisingly there in terms of the health insurance differentials. People with mental health issues were also more likely to be screened for ACEs. We also looked at attitudes around screening, and we found more positive attitudes around screening in the following groups. So women, Latinx folks, Black folks, bisexual folks, non-citizens, and those who had already been screened. So the latter there suggests that exposure to screening is associated with more positive attitudes around screening itself. In another study we looked at this year, ACEs screening was associated with higher use of preventative care and ER care. So two types of healthcare utilization, and it's associated with both. Interestingly, though, highest increases in care utilization were seen among those who did not report any ACEs. So this could potentially be bad or challenging for the healthcare system if it's leading people with no history of ACEs to seek more healthcare. So that is sort of a thing that I think we need to continue monitoring and see what is happening in the future. So what might be some issues with screening for ACEs in the clinical setting? And this is my question to you all, and some things to consider here. So what might be some issues in terms of feasibility, and what might be some issues in terms of ethics when we're undergoing clinical screening at a population-wide level? Any thoughts or ideas? Yes, Dr. Aparicio.
So what comes to mind for me is having enough response to that. Like, what do being able to handle that information? Sometimes we hear systems not wanting to collect information about ACEs or other things because they're like, oh my gosh, how are we going to deal then with responding?
Yeah, so a big question there is, you're collecting information, and then do you have the capacity to do anything with the information you're collecting? Other thoughts here in terms of issues? Yes, Samaya.
Time constraints, like most times primary care visits are just short, and most people would be focused on like the symptoms, so there will be no enough time to go through.
Yeah, so oftentimes what we hear from providers when we ask them to do something new is, we already have a bunch of things we're trying to do. We don't need something new to do. So it's a question of whether we, in terms of as a healthcare system and specifically with providers, do they have enough time to do the screening and to do it well or appropriately? Let's see, re-traumatization. So yes, this has been a concern reported by many in terms of what it might mean to ask people about traumatic past experiences and whether this might be stressful to do. The other thing that I consider here is that if you know you're going to be asked about traumatic experiences and you don't want to be asked, then do you avoid getting healthcare because of that potential ask? Other ideas? What might be some ethical issues here? Do we think a 2-hour training is enough to have a provider effectively trained to screen and to do something with the screening results, particularly to the clinicians in the audience?
I'm not a physician or clinician, but I was concerned about training. Just realistically, folks do they have the ability to respond appropriately based off of the information that they find out from the screening? And if that's not the case, is it more helpful, more hurt than harm, more harm than good?
Yeah, so you have to think about, again, who would be doing this screening. This is going to happen in primary care settings. So in primary care, we're not talking about trained psychiatrists, social workers, et cetera, who have more of the training with asking information about trauma, dealing with the consequences of those asks, et cetera. That isn't who would be asking these questions. So they're really starting at a lower level of knowledge on the subject matter specifically, and then expecting them to do something to address if someone gets flagged as having a high level of ACEs. The other thing related to our earlier conversation about cutoffs in terms of these scores, the coding system codifies a cutoff, and that cutoff isn't necessarily evidence-based, meaning that it's really crude, and when we try to correlate it with health, it's a really crappy predictor of health, specifically using that cutoff. So whether or not we're codifying something that is bad should be something we question here specifically. And there's some related concerns around you can have high ACEs and not experience any negative health consequences, and you can have low ACEs and experience a negative health consequence. So the score itself is not deterministic. So there's some challenges with trying to present it as such. This leads us now to discussing some of the dilemmas that come with this rollout of ACE screening incentives. So the ACEs screening effort has taken off in the clinical encounter. However, we don't have clear evidence to delineate the benefits and consequences of screening. This is the other big ethical dilemma from my perspective. We don't know if ACEs screening improves health. That was not something that was examined prior to the rollout of this program. We don't know if healthcare utilization improves. That, again, was not something that was examined prior to this rollout. Given the uncertainty, is ACE screening being accessed and implemented equitably? So we have issues with a program that we've incentivized people to undertake in a screening effort here specifically, but we don't necessarily know the consequences, meaning that, yes, there are some studies that have been done, but nothing lead us to be able to say conclusively, we know that ACEs screening is going to have a positive impact on health, and we know that ACEs screening is going to have a positive impact on healthcare utilization. And the biggest objections actually come from clinicians specifically, or providers who say, we don't want this to happen at a population scale, that this should be done only in certain kinds of clinical settings or only when it's indicated. But incentivize it to happening broadly might actually lead to various negative consequences. More dilemmas. So the ACEs screening payments were implemented early in the COVID-19 pandemic. This was itself accompanied with a lot of different changes in healthcare utilization and delivery. So during 2021, over 20% of adults delayed or forwent healthcare because of COVID-19 specifically. So if we think about this made sense at the time when people were being told, don't come to the doctor if it's something that's primary care focused or something that can wait. We want to spend all of our resources focusing on dealing with patients who are positive for COVID. From 2019 to 2021, the percentage of healthcare claims coming from telehealth as a result of the pandemic primarily also increased, jumping to 5% at the end of this window. So that is, the rollout of ACEs screening came during a time period when healthcare was also rapidly changing. So that leads us to the study that we conducted. And we were looking at the following research questions. Is a place where healthcare is received associated with ACEs screening and related attitudes around screening? Here specifically, we're looking at where people typically get their healthcare. And then is the use of telemedicine, remote diagnosis and treatment using telecommunication technology associated with ACEs screening and the related attitudes? Finally, we also cared about the reason people were using telemedicine. So people can use telemedicine for a variety of different reasons, and are those associated with screening? The data source. So we got data from the 2021 to 2002 California Health Interview Survey. So this is an annual survey that's conducted in the state. So they actually do 3 different surveys within this. So one survey looking at the health of children, one for the health of adolescents, and one for the health of adults. So this is data specifically looking at the adult survey. It's an annual web and phone-based survey that's conducted in multiple languages, more so than a lot of the national surveys, actually. So that's one of the big advantages of the CHIS. It's representative of community dwelling adults in California. It's cross-sectional, and for this time period, there was over 45,000 respondents who had complete data. The outcomes we were examining were a few. So the CHIS begun collecting data specifically around ACEs that are quite helpful to the ongoing monitoring of the ACE screening rollout. So they asked questions of adults, specifically looking at whether or not they had been screened for ACEs by a healthcare professional. So that was a yes or no question. And then they were also asked about their attitudes around healthcare providers asking about ACEs. So did they think it was very important? And there's a Likert scale, and we classified it as yes, they thought it was very important versus everything else. Lastly, how satisfied they were with providers or clinics' efforts to address the impacts of ACEs. So were they very satisfied versus everything else, again, on the Likert scale. The independent variables we were looking at here were measures of healthcare access and utilization. So the first was the usual source of care. So the place people usually go for medical advice or care. So first, no place, so they don't have a usual source of care. Interestingly, though, when you look at data, you have people who report having health insurance, but still report no usual source of care. The next big category included a doctor's office, Kaiser or HMO. Then we have a clinic, health center, or hospital clinic. Next was an emergency room. And then we have other no one place. Of these, in terms of the actual places people go, we typically don't want to see people going to the emergency room for their usual source of care. That's typically not what the emergency room is designed to do. It's also not best for the patient or the healthcare system if people are going there for the usual source of care. So if you're going there because you need a regular physician visit, you're clogging up the ER, it's going to cost you more money, et cetera. It's just not the best in terms of health services, what we want to see people do. The other outcome we examined was use of telemedicine in the past year. So did they use it or not? And then as a follow-up there, among those who did use telemedicine, they were asked the reason why they used telemedicine. And these included several, including things like a skin problem, eye problem, mental or emotional health problem, et cetera. We looked at a variety of confounders to try to rule out alternative explanations in our multivariable analysis. So the number of ACEs reported. So the CHIS asked an expanded version of the ACE questionnaire that included all of the specific ACEs I highlighted from the Burfess, along with racial discrimination and a few others. Then they also report a bunch of demographic characteristics in the in the CHIS. We chose race, ethnicity, gender, age, marital status, citizenship status, household income, and educational attainment. We also accounted for access and utilization of healthcare, so their current insurance coverage type and whether or not they had visited a doctor in the past 12 months. Lastly, we accounted for need. So one of the big things we see in ACEs research is that people are more likely to use certain kinds of services that we would actually want them to use because they should need those services more. For example, specifically behavioral health services. So we want to account for the need differential. So we looked at health status and serious psychological distress in the past year as potential confounders here. Our analysis was conducted in Stata 18 using jackknife replicate weights, and this accounts for the complex survey analysis or complex survey structure of the CHIS. Logistic regressions were used to calculate odds of study outcomes while accounting for confounders. Most analyses were conducted among all participants, with the exception being the sub-analysis among participants who had actually used telemedicine in the past year, looking specifically at the reasons that they had used telemedicine. So our results. First, the sample characteristics. Overall, only a small percentage of adults reported being screened for ACEs. So in our full sample, that ends up being a little over 7.5% of adults being screened for ACEs. So I want to note that this is in contrast or a different kind of data source than the source of data I noted earlier that showed the number of people who had been screened for ACEs, because that data comes only from Medi-Cal patients. So this is a different way of collecting this data that isn't restricted to only Medi-Cal patients. So probably a more accurate representation of the population levels of screening in the state. Most respondents thought it was very important for providers to ask patients about ACEs. So here, favorable attitudes towards being asked about ACEs. And a minority of respondents were very satisfied with efforts to address the impacts of ACEs by providers and clinics. So here, an opportunity for growth and improvement in both educating patients in terms of what clinics and providers are actually doing to address ACEs, but also leaving room for clinicians and providers to do more to address ACEs. So in terms of the independent variables, most respondents had a usual source of care. So this is fairly consistent with other research in California and nationally that in population surveys, most respondents report usual source of care. Here, the most common usual source of care was a doctor's office, Kaiser, or HMO. And we had here a minority of patients getting their healthcare from the emergency department here at about 1%. Nearly half received care from a doctor via telemedicine. So again, I wanted to remind you that this data was collected shortly after the pandemic had started, so not surprising given that context. The most common reasons for getting care via telemedicine were to receive a test results or follow-up care, that 42.84% of respondents, because of flu, cold, or allergies or infections. And then the third most common reason being muscle problems or pain. So people are getting telemedicine or using telemedicine to receive care for a variety of different reasons. So now let's look at the multivariate results here, and the three outcomes we were examining here specifically. First, if they had ever been screened for adverse childhood experiences by a healthcare professional. They believed it was very important for a healthcare provider to ask about ACEs, and that they were very satisfied with the provider or clinic's efforts to address the health impacts of ACEs. So what you can see here is that among those with no usual source of care, so they report that they don't have a regular place where they can ask healthcare provider questions or get treatment, those individuals were less likely to get screened for ACEs. They were also less likely to have favorable attitudes around getting screened for ACEs or getting asked about ACEs specifically. On the flip side, those who went to the ER for their usual source of care were more likely to be screened for ACEs. At the very bottom there, receiving health via telemedicine was associated with more likelihood or higher odds of being screened for ACEs, and also more positive attitudes around being asked by a provider about ACEs. When we examined reasons for using telemedicine, only use of telemedicine for behavioral health was associated with ACEs screening and more positive attitudes around believing it was important for a provider to ask about ACEs. So meaning that most of the reasons people went to or utilized telemedicine weren't associated with our outcomes. So what does this all mean? The context for care seems to matter when it comes to ACEs screening. You're more likely to report getting care from ER or use telemedicine. Or sorry, the ACEs screening is more likely to occur if you're getting care from an ER or using telemedicine. In the context of ER care, ACEs screening may be more relevant to treatment, and or people who use the ER might have a higher burden of ACEs. And you think about the people who get ER treatment in truly emergency cases, such as a mental health crisis, that might make sense. In the context of telemedicine, this environment may make patients and providers more comfortable. So being able to dictate the setting of your care where you aren't having to interact with, for example, clinic staff and have other patients potentially hear your conversations, etc. For both, we need more research to figure out what is actually driving this. So why are people more likely to get screened when they're using telemedicine or when they're getting care from the ER? If people use telemedicine for behavioral health, they are more likely to report being screened. This makes sense given the common practice of understanding trauma in delivering behavioral care. So it's more common practice in terms of the workup for an individual patient to do that kind of screen. Overall, results suggest that there are disparities in ACEs screening that depend on the context in which healthcare is delivered. Part of this isn't surprising because the money to screen goes only to providers from private insurance or Medi-Cal. So there's a lot of holes here in terms of providers not being incentivized to screen certain kinds of patients. And we know from other research that the kind of coverage you have does have some bearing on the quality or type of care that you're able to receive. However, because we don't understand the benefits or burdens of ACEs screening, we likely won't understand the impacts of these policies for years to come. So that's the other, I think, big takeaway, that we don't yet know, and we are likely not to know in the near future, what the upside and downside of doing a pretty large scale clinical screening effort for ACEs is going to be. I hope, and this is sort of my bias here, that it does have a positive impact on health. I suspect it will, but that doesn't mean that there are potentially vulnerable subgroups within the population that won't be turned away from or turned off by the prospect of getting screened, so that they won't use health services. And that doesn't necessarily mean that every clinical practice is ready to do this kind of screening. So we might need more intensive training and follow-up and evaluation efforts to truly understand what is happening. Until then, it's important for researchers and policymakers to continue monitoring this policy work so we can understand this. And specifically here, that this kind of effort might not stop at California. So there's reasons for other states to be looking at California to determine whether or not it makes sense for their states to do something similar. And once we have more evidence, I think that we might be in a better spot to determine how future rollouts of these kinds of programs can take place. So thank you to my collaborators for this research that was reported here. And I also wanted to leave some time for questions or comments about anything I presented. So question here, wondering which medical specialties typically conduct a screening and under what circumstances are they done intentionally as part of the screening program or only during routine patient history taking? So this is a great question, and I would love clinicians to chime in here, but it isn't standard practice, I believe, anywhere but behavioral health. And even then, they're not doing a formal ACEs assessment, I don't think. It's more of the patient history taken. But if anyone wants to expand on that, please do.
So I can speak to like a clinical setting in terms of mental health. So typically, if someone comes to a therapist and they're coming for outpatient mental health, say, the assessment is a biopsychosocial assessment that is their entire, family history, that sort of thing. So it's not, sometimes people will use standardized measures to be able to look at change over time, like the child behavior checklist or something like that, to kind of get a baseline and see how they move over time. But something like ACEs, I don't know if it would be used in that same way, like you were saying. Like, I think it would be more of a discussion about the things that they'd experienced in their life leading up to that point, which may include adverse childhood experience. So I don't know if it's used in the like checklist kind of way, but it could be used.
Yeah, my understanding is that the only real context in which this was done on any large scale prior to the recent efforts in California would have been in the Kaiser setting when the original study was done. But outside of that, some of the items are identical to questions that are asked, but the ACEs scale as a collective isn't typically what was being collected from patients. Other questions?
I have a question. Are you aware of this being used in any clinical settings for not just like general information, but also to then say, you know, which ACEs are associated with which outcomes to then sort of lead to further screening? Just curious about that.
That is not something that I've heard of being done in clinical context. So that is something that I've seen researchers do, including myself, where we try to look at the individual items to see if they're associated with outcomes. But I don't know of clinicians, which is why I think, for example, some of these ACEs items might be really relevant for doing follow-up for some kinds of services, but um, I don't see them being done systematically. Dr. King Marshall.
Do you have thoughts on how we can incentivize mental health providers and primary care practitioners to screen for ACEs for those that might be hesitant and worried about like one training and or just the time in addition to all the other things that needs to happen?
Yeah, so I think the California case shows us that we financially can incentivize, and it seems like they're very receptive to that. I think the other thing is that in the context of something like an HMO, where they are getting paid per patient to care for patients, I think if we have evidence to show them, hey, there are better outcomes when we have tailored care that's delivered to patients with a history or a high burden of ACEs, that might help them. But I also am hesitant to say that we should be further incentivizing it because we don't yet know what the long-term impacts of it. So I'm really torn by this, that I personally believe that the screening efforts are probably a good thing, but I have some ethical trepidations with this uncertainty of it all.
And then actually I did have a follow-up questions about like what could possibly be the benefits, like because you said that we don't really know. What are your thoughts on how or where we can see those benefits?
So I think if providers truly are able to, for example, modify their care delivery based on understanding a history of ACEs, so I can give a concrete example. So in the context of cervical cancer screening, if we think that people might avoid that procedure because of re-traumatization, and we know that we can screen them for ACEs, determine whether they have a history, and then potentially modify the procedure based on the results of that. So that it can include maybe a trauma-informed approach where the procedure is slowed down, there's more conversations about what's happening, or it could include a home collection kit, which we can do that in the context of HPV screening. So we can send people home or send them home with a kit or mail them a kit themselves, which they collect the sample themselves and mail it off. It's not going to be as accurate in terms of detecting HPV, but it's still going to be better than if they got no screening at all. So I think that we can use that information to modify procedures in a trauma-informed way. The other thing is we can think about what it might mean for whether people might, for example, adhere to treatment or not, because we think about all of the things that ACEs are associated with, and that might include things that might make treatment adherence more challenging. So things like substance use, substance abuse, which might interfere with treatment, um, being more likely to experience low SES, which might impede access to treatment. They're also more likely to not be insured. So again, more challenges with adhering to treatment. So if we can try to use that as a flag to provide more services, that like the social service aspect, I think that might be beneficial to patients.
Great, thank you.
Any other questions? Okay. Well, if not, thank you very much for having me.
All right, thank you all for attending. Let's all give a round of applause. Dr. Alcala, thank you so much. I've learned quite a bit. We really, truly appreciate that. Thank you all. I have just put into the chat an evaluation link. If you can take a moment to complete that evaluation, we'll also be following up. We're coming up to the close of the fall semester. I hope everyone has a great end of the semester, stays warm, enjoys the snow day. Our next PRC seminar speaker series is on February 13th, and we are lucky to be joined by Dr. Preitzmeier. And I believe that is it. Thank you all. And again,